Yeah, thank you so much for the nice introduction. It's always a pleasure to share the podium after your nice presentations. So it's not easy to make a good SWIFT from all the data we've just heard from Dr. Peitinger, from yourself. But I'm just going to try to make it from a clinician point of view. We've seen that endocrine therapy is everything else but a boring issue. It's not just getting a pill or an injection. It is, as Professor Muck has shown us, a very dedicated, it's a masterpiece between the endocrine environment and the tumor behavior. And everyone who is treated actually with metastatic disease has shown that most of them failed endocrine treatment of those who had an adjuvant treatment, how long and in which composition. And it was almost a couple of years ago an indication that these patients are subject to chemotherapy. So here are my disclosures. All those pictures you're going to see here in this cartoon are showing us that we have to understand that breast cancer is not a single disease. We have these subtypes in luminal A and luminal B, and all these subtypes have predicted somatic mutations. We don't understand these amount of mutations, but you're going to see this very easily here, that the well-known mutations in luminal A and luminal B cancers are totally different. So these are easy to understand for us as clinicians, luminal A and B categories, but I think in terms of endocrine sensitivity, they're totally different. So these were the good old days of research. Dr. Beetson realized a problem. He had no clue about the mode of action, what ovarian ablation might be. He published it properly and he set up standard of care. So that's the beginning of a very well-known treatment. He never understood what a hormone is. There was no idea what a receptor is. It was just a genius idea. Take off the ovaries in metastatic disease, stage 4 disease, and bring this to our attention. So the breakthroughs over the other years in endocrine treatment of metastatic disease were just a sequential way of downregulating circulating estrogens. It started with tamoxifen. It was a question of re-exposition. We've learned the story of the aromatase inhibition. We've learned the stories of the downregulations, and we didn't pay much attention about what is actually causing the progression of the disease in the metastatic setting. Is this really a lack of efficacy, or is this an issue of endocrine resistance? So if we have endocrine resistance, does it make any sense to re-expose an individual who has just shown that this route of administration internally and downstream from a receptor is working? So over the years, starting from George Beetson until we are sitting here and speaking, we have tons of new drugs and combinations, and we need as much as patients, these big mega trials, 2,000, 3,000, 4,000 patients, to show where the differences is. So if you recall how many patients have been sacrificed to identify one of the best aromatase inhibition, and at the end of the day, these are 3 flavors with no big differences. So just catching up with Dr. Muck's presentation, when we are just going to speak about endocrine modulation or endocrine treatment, we try to target the estrogen receptor. We do not pay much attention about the subunits, if that's the alpha or the beta unit. We just take it as granted, ER measurement, immunohistochemical staining, and then if it's positive, we shoot with endocrine treatment. If you can see the distinctive post-transitional modifications of resistance you're going to see in this cartoon, you might identify some of the candidates which are targeted now by the combination treatment to overcome this resistance. And before we deep dive in those molecular mechanisms, I just want to draw your attention that ER and PR are totally different receptors. I just take the liberty to present to you a data from Sweden. What they did in a cohort in a retrospective study, they looked at luminal A cancers, So age was not a big issue, less than 40 or older than 40. But in those individuals, when you just see the discriminator is younger or older than 40 years, in those luminal B cancers who are expressing the progesterone receptor, the Kaplan-Meier curves in terms of disease-free survival are obviously totally different than in the luminal B cancers without PR expressor, and these patients are all exposed to tamoxifen. So if you're going to look at this subunit or subcohort in more specific means, and you're going to see what's happening here, to bring this to a clinical situation when you have a patient who has ER-positive, PR-negative setting, and that might be in the adjuvant setting and that might be in the metastatic setting as well. The question is, are these the same kinds? And my answer is they are totally different. You're going to see this here and make it very simple. Luminal B cancers with low PR expression in this cohort, as they are as bad as triple negatives or HER2 positive, and at that time they were not exposed to any anti-HER2 treatment. So then there were tons of resources were spent using somatic driver alterations to answer this simple question in the big 198 study. One of the cornerstones in bringing to our attention in the adjuvant setting what is obviously the best of ways to do it. And they tried to find any driver alterations, and they found not as much. The only thing which might be of clinical relevance, but this is from another trial or from another paper, might be PIK3CA mutations, but we don't have a test which is running in clinical routine. Here you're going to see in this cohort, in a cohort which is mutation positive, and these are the wild types. There you see a difference, and this is clinically meaningful if you have this information, which drug actually might help you the best, and in the wild type there's obviously no difference. So then people try to establish a kind of a sequence what endocrine resistant might be, and this is, even if you just inhale it, it's very complicated what is an early and what is a low and whatever resistance. So I think this was not traveling, and it was Fatima Cardozo and the ABC meetings, which are run in Lisbon. They showed it very easily, and it makes sense what it means that you have an endocrine-sensitive patient or an endocrine-sensitive tumor in both settings, adjuvant and or metastatic setting. So when you have a primary resistance, it doesn't make any sense just to throw some other endocrine treatment to this patient. You will never break through this resistance. You just play on chance, and I think that is not the right way of doing it. So we don't discuss this way because it takes hours, but it shows there are certain pathways who are actually responsible for this endocrine resistance. And this cartoon shows very nicely in the corresponding colors that we have certain ways of new combination with endocrine treatment options to overcome this endocrine resistance. And the only reason why we are doing this is to postpone the onset of chemotherapy. So that's the only reason to do it besides basic science. And we're going to start here with the mTOR signaling pathway, and that has been shown with one of the, for me, most interesting data, and that's the TAMRAT trial from Thomas Bachelot from France. He was asking the question, if I add a drug, and that was everolimus or RAT001, to tamoxifen, could I overcome this endocrine resistance? And what you're going to see here in TTP and overall survival in this whole cohort, there is obviously a way of doing this in a smart way of combining those drugs, not only, and actually not only to see who is super sensitive, really to break through this endocrine resistance. And the beauty of that trial, for those who had the pleasure to read the paper in full, that he could show very easily that in primary hormone resistance cancer, there's no difference. So it doesn't make any sense if you go back to the definition of endocrine resistance if you don't have a more deep dive diagnostic procedure to see if there are some alterations happening, to just expose them to aromatase inhibition or something else. If you have those patients who have a secondary hormone resistance, so they showed that in one of the previous treatment, the endocrine treatment was working in terms of a clinical response or at least no progression, then you can go on with your treatment options. Same thing was done in the Bolero-2 trial. So there was everolimus and exemestane versus exemestane. You're going to see here that there was a very nice difference in progression-free survival, but it was not translated in an overall survival. It's a question on the judgment of the physicians, what endpoint is meaningful for your treatment options. And again, Gabe Hortibaji did a deep dive analysis to see if there are any biomarkers that could give us an idea who might really benefit, and then he published this very nice paper in 2016. It is visualizing that there might be a difference of the inactivation of certain genes or wild type or the mutated status, but in his conclusion he stated there is no much difference in terms of overall survival that we identify any of those biologic drivers. And then the next history was, or chapter was opened by identifying this pathway and the introduction of the CDK4/6 inhibitors. And again, like in the aromatase inhibitor times, there are three friends running the show, palbo, ribociclib, and abemaciclib. So it's very important that these are targeting the same pathway, but they're totally different drugs. You're going to see this here not from this, only from the scheduling, some of the side effects. So you have to have your own experience to identify your perfect drug. You're going to partner this with endocrine treatment. And then all those three drugs have tons of new trials, and they are listed here in first line and second line treatment in metastatic disease. And interestingly, at ESMO and ASCO, we have seen updated in overall survival. So never ever that was estimated. And in all these trials, there were secondary endpoints. So nobody was so tough asking the question, my combination can alter overall survival. But anyway, these are the data that every one of you is familiar with. The CDK4/6 inhibition in almost with aromatase inhibition, showing a very early onset of breaking through or overcoming this endocrine resistance. They are almost superimposable, all these three trials. And you're going to see the same thing is then the question, what is the best partner for them? Would this be an aromatase inhibition or fulvestrant? You know, all this data, head-to-head comparison of these drugs. And you're going to see Prolima 3 and Monarch 2, exactly the same thing. The curves are separating very, very early. And then the question is can a chemotherapy be more active, or do we have to understand that these combinations are at least as active as any given chemotherapy? So you're going to see this here. What all these trials are doing, the red point here or the red dot is the onset of first-line chemotherapy in metastatic disease. And if you do have not chemotherapy-resistant cell clones, with these smart combinations of treatment, you can really postpone, regardless of the drug, the onset of chemotherapy. So what's on the horizon then? And you have been witnessing the data of the SOLAR-1 trial. That is targeting the PIK3CA mutation, totally different pathway, and then that is the onset of this trial. You're going to see fulvestrant and abemaciclib and in various combinations. And the outset here is that there is obviously a new way in these patients where you can find these mutations, but you have to have a lab that is running a valid test to give you a really answer if you have a difference in that. And the final publication of this SOLAR-1 trial is showing you very nicely in these waterfall plots. These are the PI3K mutated, and you're going to see the majority of these patients in the combinations are responding, whereas the wild type is not doing this. The question is, at the beginning or onset of your treatment judgment in metastatic disease, do you have all this information at hand? I think we need this panel testing. It should not only be done when you just realize that you have a progression of the disease, the patients are not tolerating this anymore. Just briefly at the end, I'm going to show you the overall survival data for those of you who have not seen that. This is in the premenopausal setting, Mona Lisa 7, ribociclib, and endocrine downregulation plus minus ovarian ablation. Secondary endpoint, as I mentioned previously, has been demonstrated here. You're going to see this endocrine treatment compared to ribociclib in premenopausal patients. It's an overall survival benefit, and that is shown here also in this subgroup. And one of the interesting questions that has been published at ASCO this year was the Young Pearl trial from Asia. And they were asking the question, is capecitabine competitive to ovarian downregulation, exemestane, and palbociclib? And if you see this, even if you might question if that is a proper chemotherapy in this setting, you're going to see there's evidence that endocrine treatment, if that is composed in the right way, is obviously a very strong weapon to compete with hormone receptor positive, HER2 negative metastatic breast cancer. Mona Lisa 3 is showing the same thing here in postmenopausal woman, secondary endpoint, overall survival. The data that has been shown here is a relative risk reduction of about 28% in this combination, early diversion of the curves. You're going to see this here. Again, the time to postpone chemotherapy is in favor of this combination, which is very good evidence that it's active. MONARCH 2 overall survival with abemaciclib and with fulvestrant. That's a cartoon here. You see this very prominent early diversion of progression-free survival that is translating in overall survival setting, and that is very good news. They did it what Thomas Bachelot did. They were looking for primary resistance and secondary resistance, and that shows very nicely that you should really early on start with this treatment, time to chemotherapy in all those combinations. That is in favor for the combination. And even those patients, even if I don't show you the slides, are doing better if then they are devoted to their chemotherapy. So the summary here is very easy and straightforward for you as a clinicians. This combination of CDK4/6 inhibitors in first and second line treatment with a proper endocrine treatment is improving overall survival. So my question is, what more are you asking for? We have to be smart here in translational research to see if we can really identify who are super sensitive to this treatment, to let them enjoy a long duration of these treatment options. So this is my personal take home for you guys. And in these patients, I think we have to make very early in the hormone receptor positive setting an idea of BRCA positivity or negativity. This is not linked anymore only to triple negative treatment. The majority of the patients are hormone receptor positive, so if you do your calculations right, you realize that the majority of patients with BRCA mutation have an endocrine sensitive status. So based on that, you decide then if it's ER high or low. And then, as I mentioned, with the SOLAR-1 trial, you would like to have this information. So this is a really sequence of a modern development of endocrine treatment in metastatic disease. And that is exactly like you're going to see this in triple negative. So if the future is bright, we should have an idea how we're going to prepare it. I think in metastatic disease, upfront panel testing might give us a good idea. And the second question is then, are these drugs all available? But this is not science. This is what everyone has to consider. So I think that's a good idea and insight that metastatic breast cancer, endocrine sensitive breast cancer is really an ongoing field of research, and I really thank you so much for your attention and being here. Thank you so much.